today I am back, and we're going to do a third episode of Season 2, if you don't mind. Again, I'm trying to keep up with 1 week, short episodes, quick-hitting topics, and kind of like to do current events if they're relevant. But, I don't think there's been anything this week that's been necessary to talk about on this particular podcast. The week prior, Bob Saget and Betty White died, but there really isn't a ton to talk about with either one of those. I made a YouTube video about the Bob Saget case, just basically talking about what happens when we find somebody dead in a hotel room, the kind of things that we look for. And then Betty White, she was almost 100 years old, and so she lived longer than most of us, and there really wasn't a whole lot to say in that case. So no current events this week to talk about. So we're going to talk about what are the moments during autopsy that are faint-inducing. In other words, what will cause people to faint or cause people to run out screaming or cause people to never want to ever talk to me again, at least from an autopsy perspective. I think I've made a lot of people never want to talk to me again, but that's more of a personality trait. Anyway, the reason why I did this is because I have a lot of people who ask me, what can I do to get into your field? And it's tough because a lot of states won't let people come and watch autopsies. So therefore, you have a lot of people who can't observe a case and know whether or not they could handle it. So I'm going to tell you, if you can see an autopsy, you should. And certainly if you're in the health professions, I think it's a little bit easier to get in and do that. And certainly if you're going into a field like mine, usually you can find somebody that will accommodate you. But I also get asked, what should I look out for? Am I going to handle it? Am I going to fall to the floor and faint? And the answer is, you really don't know until you do it. Okay, so my first case, which I think I talked about it in one of the podcasts that I did last season, and I wrote about it in a magazine article, and it was anxiety-producing, but it wasn't a fear moment. It wasn't something where I really felt like something I was going to, snap or something. And so I managed to handle it. I think that you have a first in every kind of case. You'll have like the first person that's your age. You'll have your first child. You'll have your first murder. You'll have your first horrific industrial accident. And so every new first brings up new opportunities. And so, it's really difficult to predict how you'll respond. But I'm going to do a real quick podcast here and talk about my observations of when people kind of like lost it in the room. Either they, they started to faint, or they just felt sick and ran out, or whatever. And so there's really just a handful, and they're pretty specific. So, first is just opening the body bag. You have a body there. This used to be a person who was animated and walking around and talking and probably didn't know they were going to die. That can sometimes be a little bit jarring to people. If they're in healthcare, that usually they do just fine with it, but a lot of times we'll have people who are not in healthcare who come for their first autopsy. And this would be like a rookie police officer who hasn't seen a case before, or sometimes we used to let people come from the community. Sometimes they would observe. They've never seen that before. Sometimes we have attorneys who will come in. They have to do it as part of being in their law office. It's just like a requirement for them, or particularly prosecutors' offices. And, sometimes that opening that bag you can just see the person turning gray. And usually we kind of have to give them, kind of stop and say, hey, are you okay? Never had anybody faint on that one, but now we do kind of a preemptive thing where if we have somebody new in the autopsy, in the morgue, we will tell them kind of like a little spiel. So in other words, don't freak out. This is all about the science. It's about discovering why the person died, and ultimately it's about delivering justice if it's a legal case, or delivering closure If it's not a legal case and, it's just like a natural type death, or it's something where the family needs to know why the person died, we will provide closure. And so usually when we frame it like that, the person handles it pretty well. But I always give an add on to that disclaimer, and I say, if you feel like you're going to faint, get out. Like, leave the room, because the last person you want helping you after you've hit the floor is me, a pathologist covered in blood. I'm not going to be as good as somebody who's in EMS and who's used to people in dire straits. If somebody faints in my morgue, I'm probably going to have just somebody else go deal with it, because I can't. Unfortunately, we haven't had that come up really too much, but I personally don't want to have to deal with that. So I just tell people, look, there's a door 20 feet away. You can go outside and get some oxygen. You can sit down. But just, if you're feeling weird, get out. So if you ever do an autopsy with me, you're going to get that spiel no matter who you are, like if you've never seen it before. So opening the bag hasn't been a problem. So then I always tell people that the next part is, because we draw toxicology, we try to draw toxicology first before we do anything else. And so that's blood and vitreous. Usually we get urine when we get inside the body. We can actually take a syringe and put it in the bladder. But we try to get blood externally. We try to put a needle into the femoral artery or femoral vessels and draw out blood. And that's usually not a problem for people, but vitreous is a problem. So what's vitreous fluid? So in your eye, there is a clear jelly-like substance called vitreous humor. Okay, and we will put a needle into the eye to draw that out. And I know you're thinking, if you haven't seen this, you're thinking, well, why would you do that? That just seems, like unnecessary. Well, the fact is, with vitreous fluid, it's actually an excellent fluid for toxicology, and it's very good for some things. Number one is alcohol. If you're looking at a blood alcohol concentration and you get the vitreous alcohol concentration, you can make a comparison, because the vitreous lags behind in metabolism by a couple of hours, and you can actually make a comparison and say, was this person still drinking and still raising their blood alcohol? Was this person at equilibrium, or was this person kind of like already metabolizing and had stopped drinking? Sometimes that's relevant. Second is electrolytes. So, you've got like sodium, and I'm not going to go through every electrolyte. Potassium's not good for the vitreous, but sodium is. So if you have hypernatremia, high sodium, or hyponatremia, low sodium, it's excellent to look at the vitreous for the electrolytes. Okay, so lastly would be glucose. And glucose is, of course, the blood sugar. And if the glucose is very low, it's not very helpful, because after death, your glucose gets sucked into your cells as they're kind of like, basically struggling to survive. All the glucose is going to get used up, because ultimately your cells want to survive, and it'll use up all the glucose in the area. But if the glucose is high, that can be very useful to tell you if somebody was having a diabetic complication, such as diabetic ketoacidosis. And that would be the other thing that you're going to look for in vitreous is ketones. Now, ketones, I'm not going to go through the biochemistry of ketones here. It's a little beyond what we need to do. But we're going to have ketones in there if we're having a diabetic ketoacidosis. So vitreous fluid is very important. And I probably went on a little bit of a tangent there, but I wanted to give you a little background on why we do it. We don't do it just to see if people will pass out. We do it for a reason for our decedent, our patient there. And a lot of people don't do well with that needle in the eye. I've noticed a lot of police officers will tell me, I can't even look at the body while you're doing it. So sometimes we'll give them a little warning. We'll say, hey, we're going to do vitreous, and then they can sort of stare into the wall or look out the door or something like that. So, there's a natural aversion, I think, to seeing a needle go into the eye, but that would be one of the other times where we've had people have to leave. Okay, so that's the vitreous draw. Now, the next part is going to be the opening incision. And for me, that was the big one. When I was a young pathology resident, and I was getting ready to do my first autopsy, that's the one that really I was worried about. Like if something was going to happen physiologically to me, in other words, because, you have to kind of press on the skin and you have to find where you're going to cut. And usually you start at one shoulder and you come to the center of the chest. And then you start at the other shoulder and you come down and form a V, and then you draw it down the abdomen and you form a Y. That's why it's called a Y-shaped incision. And my first autopsy, the woman had died very recently and like within the last couple of hours. And so when I pressed on the flesh, to kind of like map out where I was going to cut, it was very soft and very supple and very much like a living person. And so the difference is with someone who's been dead a while, like many hours or a couple of days, and in the cooler, usually the body is a little more firm. So rigor mortis is set in, and the muscles are firm, and the soft tissue itself is a little bit harder because as you cool the fat down, it becomes a little more waxy. I always tell people, okay, opening incision is the other one, and frankly, everyone seems to do pretty well with the opening incision, more than I would have expected. But really what comes after the opening incision, I think, is the one that bothers people, and that's opening and taking the chest plate off. Okay, what do I mean by chest plate? If you feel the center of your chest, there's a very hard area, and the common name for it is the breastbone, but it's the sternum. That's the name of the bone, and from that, the sternum, the ribs kind of come from the vertebral bodies around and attached to the sternum, and that's the rib cage. So you have to take off the chest plate, which is the anterior ribs in connection with the sternum. Well, how do we do that? There's two ways we do it. One is with a saw, and that's usually not a problem for people. You turn on the bone saw, you press it through the ribs, you go all the way up to the sternoclavicular joint where the clavicle meets the sternum, right in the middle, and then you can dissect it right off, no problem. But sometimes we use loppers, okay? And I just had talked about that before if you've been listening to my podcasts. Loppers are like branch cutters, and they are literally from Lowe's or your local hardware store. Lowe's should actually sponsor me. So anybody listening to this, Lowe's, if you want to just sponsor me, and or maybe Home Depot, you can sponsor me because we're using your cutting tools to open ribs sometimes. But anyway, to preserve the bone saw, sometimes we won't use the saw itself. We will use the loppers. And they crunch. So when you cut through each rib, there's a very loud crunch, and it is the crunch of bone. And so that has caused issues with people as well. Because it is an unsightly kind of thing to see that, but that is a very common tool for the forensic pathologist. It's common because it works really well, but it can be kind of unusual to see that. And I know that many forensic pathologists will use those, and some people will just use the bone saw. Again, we don't always use the saw because we don't have a lot of backup saws and backup blades, so we try to preserve the saw itself. But I'd say 30% of the time I use a saw, and 70% of the time I use a lopper, so like big cutting device. And it's mainly not necessarily the sight of seeing that, but the sound, because not very many people are accustomed to hearing the crunching sound of human bones. So next would be after we take the chest plate off. If you've made it that far, you're doing pretty well. There's a very good chance you're going to be able to make it through the autopsy. But once you open the abdomen, once you make the incision through the skin, through the subcutaneous tissue, and through the peritoneum, you open it up, invariably you get the smell of the intestines. Okay, so the smell of the autopsy comes from the intestines. And why is that? Well, because bacterial growth in the intestines produce aromatic compounds that don't smell very good. They're sulfur-containing compounds. So if you have a really strong sense of smell, sometimes that can bother people. I know the smell, and it gets worse as decomposition proceeds. So if you autopsy somebody a couple of hours after they died, there's really not much of a smell at all. But the longer you go, the more bacterial growth you have and the more aromatic compounds you have. So that's problematic for people who have really strong senses of smell. Now, lately it's not been as bad because with the pandemic, most people are wearing a pretty good fitting mask during the autopsy because, obviously we have COVID maybe in the air from aerosol production with sawing open the body and whatnot, splashing of fluids, but also the living people that are there. You know, I'm more concerned about getting COVID from somebody that's living and inside of my morgue than I am the body itself. So most people are wearing masks, and as a result, that dampens the smell a little bit. By the way, a little mask hack for you, and if you haven't figured, out how to use it yet, then 2 years into a pandemic, then maybe I can't help you. But people always complain about not being able to breathe in a mask. And frankly, I don't like it either. I never liked wearing N95 masks because sometimes we'd have to wear them in med school if we had a TB patient, or sometimes we would have to wear them during residency if we had some kind of infectious disease patient or a dead patient who may have had an infection, whether it be MRSA or TB or something like that. And I hate wearing an N95 mask the whole time because I feel like I can't breathe. Well, I decided... when the pandemic started, I couldn't risk not wearing an N95 mask. So I breathe through my mouth. And so I'm a mouth breather, basically, right? But I breathe through my mouth, and I find that the sensation of the smell isn't as bad. So if I have a decomposed body, if I have a really smelly body for some other reason, if I have a burned body, which can be very kind of caustic smelling, I don't smell it very much because I have my N95 seal, I breathe through my mouth, and I don't have as strong of a sensation. So if you ever want a little hack there, just become a mouth breather for a little bit while you have your N95 on. Also, the other bad one in terms of the bowel is the stomach contents. So people always ask me, is there anything that makes you gag as a pathologist? And truthfully, no, I have a really strong stomach. But stomach contents are disgusting, absolutely disgusting. Because, a lot of times you can see exactly what somebody was eating right before they died. And, it's... obviously, right? But sometimes, it's chewed up well enough, or it's just like a paste type material. It's not so bad. But the problem is that once the food and drink hit the hydrochloric acid in the stomach, you start to get more aromatic compounds forming. Sometimes it can be really acrid smelling. And then if you have any decomposition setting in, stomach contents are really way more horrific than the bowel contents. So sometimes the stomach contents will cause people to feel sick and want to leave. There was one coroner that I worked with, and she was a seasoned coroner. She had seen all of these terrible things, and sometimes she would come into my autopsies and watch. But when it was time to cut the stomach, I had to warn her. I would say, hey, we're getting ready to cut the stomach, because that's the one thing that she could not stand, was seeing the stomach contents. And I agree, to this day, after thousands of autopsies that I've done, it's still the worst part of the autopsy for me. And I had one case once, and I'll talk more about this case sometime in the future, but basically it was a person that died in a hotel room with the temperature, the thermostat set to like 88 degrees for some reason. And so they decomposed, and they had died essentially of an acute alcoholic intoxication. So the stomach was filled with this like alcohol decomposing food, and the heat made it all that much worse. And when I opened those stomach contents, I basically had to hold my breath for the entire time. And then I had some medical students with me, and they were completely plastered against the wall as far away as possible. And, so again, stomach contents can be horrific depending on the situation. So the next thing is, sometimes things are said during autopsy that can disturb people. Things that I say that sound normal to me and fine to me, heard from an observer can trigger a reaction. And I can think of one case, actually a couple of different cases, where we note that the body is warm while we're autopsying. So if you autopsy somebody within, say, 12 hours of death, 12, even 16 hours sometimes, the interior of the body will still be warm. Now, that's not to say that it's going to be the actual body temperature, the 98.6 degrees Fahrenheit, but basically the external surface of the body will be cool. You'll open the body up, and then as we start to dissect, you kind of feel that it's warm. And I had one case where a woman had come to the autopsy, and she basically was with somebody who had come to visit, and I put my hands into the abdomen, and I commented that it was warm. It's actually, this guy is still warm, I think I said. And I didn't even realize that would bother her. This is the first autopsy she had ever been to. And I kind of glanced over, and she looked like she was turning green. And she basically, that's the one person I've had that basically ran out. I mean, sprinted, bust the door open, run down the hall, and I literally never saw that person again. And if you know me, you've heard me tell that story a couple of times, and it may have even appeared in one of my previous podcasts. But I'm fatigued and can't remember everything that I say. But yeah, so the commenting on the body, the warmth of the body, that seems to bother people a little bit. I've had just a couple of people faint in my entire career. And one of them was kind of a partial fainting that dealt with kind of describing how the body felt. I don't know why that bothered the person, but they actually went to the ground, but they didn't lose consciousness. And then they sort of dragged her out of there. And she did a really good job because she went and had something to drink or something of that nature, and she came back in and finished the autopsy. And I was like, wow, real trooper there. I would have been gone. I would have been just out of embarrassment alone. I would have left. But she did a really good job. And then, so the sights and smells can be bad, but then you have the sounds, okay? So the sounds of autopsy, I think, can be triggering for some people. And I guess I really should have recorded this and played it here in the podcast. But it's there, when you open the head, there are a couple of different sounds that seem to really trigger people. And you know, the first is, now the last time I did an autopsy, a podcast, I described opening the head and folding the scalp forward over the face. But I didn't describe what that sounded like. There is a very thin layer of tissue on the under the subcutaneous fat of the scalp that sort of is attached to the skull. And when you fold it forward, it makes kind of a ripping sound. It's kind of a neat sound, actually. I kind of like it, to be honest. But some people cannot stand that ripping sound because it's little, almost like spider web consistency of tissue in between the scalp and the skull. And there's few things more satisfying than taking a razor sharp scalpel and dissecting that tissue away from the scalp. It's one of my favorites. I know I'm a bit of a weirdo, but that's fine. You guys knew that already. Oh, by the way, I'm a little bit hoarse right now, but don't worry, I'm not sick. I made the mistake of eating a Jolly Rancher before I got on to record this. And so basically my assistant gave me a bag of Jolly Ranchers a couple of weeks ago. I hadn't had them for like 20 years. And I've now developed a crippling addiction to Jolly Ranchers. And so I put the Jolly Rancher in there, and it melted down, and now the inside of my mouth and throat is coated with this syrupy, thick candy. So that's why I sound a little bit hoarse today. I apologize for that. Anyway, so we have the folding of the scalp. Sometimes the sight of that can be a little disturbing as well, because the skull, I mean, it looks like any skull you would see in an anatomical model. So it's weird to see a person who used to be alive laying there, and then all of a sudden, you know, you just see the top of their skull. Sometimes that's bothersome for people. And I'll have to admit, the first couple of autopsies I did, that was an unusual sight for me as well. But then we go ahead and get the bone saw out. There's no shortcuts there. You can't use loppers to open a skull. You have to go through and saw the top of the skull open and remove that calvarium. And so there are two moments, there are two sounds associated with that. The first is the insertion of the skull key. So you make a cut in the bone all the way around, and then to actually remove that calvarium, there's a tool called a skull key. And there are actually other names for that tool. I'm not going to get into that right now. But basically it's T-shaped. You put it into the groove that you just cut, and you turn it quickly. you turn it like you're, turning a knob on something, and it cracks the skull open. It doesn't produce an injury. Don't get me wrong. We're not being harmful to the body, but it cracks the remaining attachments of the skull away from the area that's been cut. And so that loud pop can sometimes be bothersome to people. And then at that point, you basically gently insert your fingers in between the skull that's still attached and the skull that you've sawed, and you pull back. And when you pull back, it pulls the periosteum and the dura mater away from the skull, the calvarium itself. And when it pulls it away, it's yet again another, almost like a sucking and ripping sound at the same time. It's got a kind of a hollow sound to it, and that sound can be really unusual and disturb people. And but again, a handful of people have been troubled by this. And I will say this: in the future, I will record these in some kind of high definition way, and I will play them for you, or I'll have them in videos, because you really have to see this stuff, and hear this stuff. But like I said, not very many people have gone down during my cases, and I did this podcast for people who are interested in possibly attending an autopsy. Those are your moments that I've noticed that people seem to get kind of upset with. But by and large, the vast majority of people come in and they do the case and they absolutely have no problem with it at all. And I think that if you go, there's a very good chance you're going to do just fine with it. You just have to have the mindset that this is science, this is anatomy, and ultimately this is closure for the family. And when you put it in that mindset, I think you tend to do a lot better with it. You're not thinking about it as a person, a living person that's laying there. And one of the things I'm thinking about doing is making a sticker that says, I survived my first autopsy, or baby's first autopsy, or something like that, and then handing that out to anybody who doesn't have a reaction, anybody, and that can be kind of like a little chip for them, so maybe like a badge. How people used to get those letter jackets, and they used to put badges on them, or they used to put their graduating year. Well, they can put a little badge on there, a little iron-on that says, I survived my first autopsy. So I don't know, maybe I'll put that in my merch store as well. Although I don't actually have a merch store, but a lot of people have asked for that, and I'm working on it. My agent's working on it. So just be calm. I have a day job, so I'm going to get to this stuff soon. Speaking of that, I'm going to be, in my earlier podcasts, I talk about the Knife After Death website. And my good friend, who I've known for many, many years, who I've known for 35-something years, he is helping me restart that website up, and we're going to be putting a lot more content on there, because I found that my social media is limiting. Okay, so I'm on, TikTok and all this stuff, and a lot of these places will ban anything that's even slightly grotesque. And so it's difficult to teach pathology if you're not going to allow images to be shown. So TikTok is pretty much worthless for me, other than, answering questions. YouTube limits my videos if I show anything that's a little bit untoward. So we're thinking about putting that stuff up at Knife After Death. And you can see there's a little sign-up place there. And I know that there's people listening to this saying, oh man, I signed up for that a year ago and I didn't get anything from you. You're a terrible person, and you should just stop making content. But, you have to bear with me. I did have the busiest year of my career in 2021, so I wasn't able to devote time to it. And now I actually have someone to help me. And so keep a lookout for that. And you can go to the website. It's still being built kind of right now. It's still we're working on putting the content on there, and I'll keep you guys updated. But I hope this podcast was helpful. And if you do have to go see an autopsy, then, maybe this will help usher that in without too much nervousness for you. Okay, with that being said, I'll talk to you next time.